Great. So the webinar is being recorded. As I mentioned, my name is Tim Leonard-Toba. I am RNAO's Director of Nursing and Health Policy, and I'm being joined by Anastasia Harapol-Yap, who is a Nursing Policy Analyst here at RNAO. And we have the pleasure of welcoming you to our second webinar regarding RNAO's recently released report entitled Mind the Safety Gap in Health System Transformation, Reclaiming the Role of the RN. I hope that today greets you with some resemblance of spring weather. Certainly where we are positioned right now, it is beautiful sunshine and warmth, and hopefully you are experiencing something similar, and we do appreciate the time you've taken to be with us over your lunch hour today. And I want to bring your attention to a website, so rnao.ca/mindthesafetygap. Now, we will have that on the slides moving forward, but that really is the one-stop shop for the report, background information, as well as where we are archiving these webinars. So if you have a friend or a colleague who's unable to attend today but is interested and would like to view the webinar, they can access it about 48 hours after today on that website. And I should note that we are anticipating a large participation today. So you should be logged on to the WebEx platform, and we're going to begin about a half an hour of a presentation, followed by an opportunity for some Q&A. Given the large volume of people on the teleconference, we're actually going to ask that the Q&A be focused on the chat box within WebEx, and between Anastasia and myself, we will coordinate that. If we are unable to get to your question, what we will do is we'll do our best to follow up with you after the webinar. And yeah, and so why don't then we start into the presentation. So as context, I think it's helpful to consider the nursing workforce within Ontario. We are one profession, but there are very distinct categories. We all have, that's not to say we don't have roles, we all have very important roles within the health system, and the focus is on appropriate utilization. So the RN workforce, which is the largest share, is 96,000, and this is for, the RN role is more suited towards caring for all Ontarians, but they have the unique authority to provide nursing care for complex patients, those with less predictability and less stability. There's approximately 39,100 RPNs who focus their care on those with less complexity, with predictability in a stable environment. And then there are about 2,400 nurse practitioners who build upon the competencies of the RN. And as defined by regulation under the Nursing Act, there are 4 categories of nurse practitioners in Ontario. So what we notice is that looking at the share of nursing employment within Ontario, we see that across sectors, with one exception, there is a decrease in the RN share of employment. And this was very concerning to us and certainly warranted further investigation, and hence why we have delved into the matter further in much more detail within the Mind the Safety Gap report. Now, I talked about how the share of nursing employment is changing, where RNs are seeing less of that share, NPs are increasing, as well as RPNs, and the growth rate of RPNs is quite significant across sectors. One exception being public health, where the RN share is relatively stable, and that is related to the fact that there is a legislative requirement that public health nurses be baccalaureate prepared RN. So looking at the policy agenda within Ontario, there is increasing focus on redesigning the system around the needs of people to optimize quality and as well as optimize on investment. We hear all the time about the need to maximize the spending that we currently have on healthcare. There's a shift increasingly of care to the community, and we've seen that manifest itself over a number of years. And so what this means then is that there is a high complexity of care requirements within hospitals, as well as within the community and long-term care as patients are being discharged sooner. We're also seeing exciting expansions to scope of practice, so in terms of RNs looking at independent prescribing, also looking at remedying outstanding scope of practice barriers for NPs. And really there is a need to enhance as well public health and primary care to reduce our historic reliance on illness-based care and really embracing a health system and health promotion. So, you know, we have that policy agenda before us, but the challenge in Ontario is that we don't have a provincial interprofessional health human resource plan. And so in absence of a plan in terms of where it is that we want to be from a health human resource perspective in 1, 2, 5, 10, 15 plus years, some organizations are responding to budgetary constraints by replacing RNs with less qualified providers and or rearranging the model of nursing care delivery really as a means to drive efficiency. And certainly that is what we have been hearing when we investigate instances where we hear that RN employment is being impacted. And the challenge with this is that what is it that's actually driving decision-making? And the challenge is that it's budgetary constraints that are predominantly driving decision-making and not quality, safety, or optimal patient outcomes. And that really is a disconnect with the vision to put patients first. So absolutely we need to maximize the investments that are made in healthcare. We need to make wise, prudent, evidence-based budgetary decisions. But that needs to be done quite thoughtfully. And to simply replace an RN with another provider without considering what impact that would have on quality and safety of care certainly is incredibly short-sighted and will result in more costs down the road. And so just some examples of what we've been hearing across the province. I won't get into specifics, but it's been very concerning. And in instances like the media reports that we've included here, as soon as we have a member who has contacted us about issues regarding nursing skill mix or models of care delivery, we always reach out to the leadership of the organization. We want to ensure that we have factual-based information, and we analyze the situation, and we do become vocal if we do have concerns that are related to patient safety. As a professional association that prides itself in evidence-based policy and practice, it's imperative that we have our voice heard when we feel that there are skill mix or models of care delivery that are not in the best interests of Ontarians. So some of the activities that we've been involved with thus far, and I really would like to thank all of our members who have been very instrumental in getting involved and bringing these issues forward and working with us. And some examples of that include our Stop RN Replacement Action Alert. We had over 19,000 respondents to that. We have now entered into a phase 2 of that action alert in light of the report that has come out. And I would encourage you all to sign on to that to share with your friends and colleagues. We made an interprofessional HHR plan a priority for our Queen's Park Day in 2016. This has included a moratorium on nursing skill mix changes and a stop to fragmented models of care delivery. As well, stopping RN replacement was a priority during our annual Queen's Park on the Road event. And we've also had an active media and social media presence. At our 2015 AGM, our CEO had announced that we would commence work to address nursing skill mix and organizational models of nursing care delivery. And I really want to recognize the many voices within our membership who informed and influenced this work. And it's our pleasure to be able to unveil that work today. So RNAO's model for health system effectiveness really demands optimal health outcomes. And that is going to drive effectiveness for people in terms of quality and safety, and also in terms of how we make wise healthcare investments. And 4 pillars that are very central to enabling timely access to quality care and person-centeredness are looking at evidence-based practice and policy, a full and expanded scope of practice utilization, interprofessional practice, and health human resources planning. So Mind the Safety Gap in Health System Transformation really is an evidence-based report that compared nursing human resource trends with population health and health system priorities. And what we did is we looked at what is the policy agenda of the government. We looked at what are the nursing HR trends, and is there alignment between those priorities and trends. And what we did find was that the nursing human resource trends are inconsistent with population health and system priorities. And so our conclusion is an urgent call for that interprofessional health human resource plan that would follow a transparent, evidence-based, and engaged process. Again, we have a policy agenda and a plan for very exciting transformation in terms of structure and service delivery, but we don't have that corresponding interprofessional health human resource plan to get us there. So in absence of that plan, how can organizations be making the most effective decisions about skill mix when we don't have that plan and to envision where we need to go to ensure that we have the workforce that is capable of responding effectively to patient needs? So we did release the report at a very successful Queen's Park media event. And that was on the Monday of Nursing Week, and it was a great way to cap off the Nursing Week. And that media event was attended by representatives of the government as well as the opposition, and it was hosted by RNAO's, RNAO's immediate past president, Vanessa Burkowski, and RNAO CEO, Doris Grinspoon. So I mentioned that we wanted to look at what are the policy priorities of the government. And we analyzed the 3 reports in the Patients First series that were released. And specifically, we identified 4 key themes or priorities that stood out to us. And for those who are interested in understanding the methods that we used for this extraction, there is an appendices within the report that does detail our process. The 4 key themes include reorienting the health system within community-based care. And again, the implications of that meaning that hospital care, or the goal is that hospital care would be reserved for those who have the most complex care requirements, where all else has, the community is not effectively able to support those needs because of that increased complexity. That also means then that people are going to be discharged into the community much sooner, and with advents in technology, we're going to see the complexity in care needs increase within the community as well, and certainly that's already underway. There's also a strive towards improving public transparency, providing coordinated and integrated services that match population health needs, and a drive to monitor health system performance and to improve accountability. So RNAO is very much in support of a number of the priorities to move the system forward in terms of structural realignment, anchoring the system in community, expanding mandate of the LHINs, enabling hospitals to care for those with highly complex care needs. And we also see that there are a number of nursing health human resource priorities that can get us there. And so as a nursing profession, we have, what can we offer to help drive system change? Well, first is looking at appropriate nursing skill mix utilization. And again, each nursing category has an important role to play within the health system, and it's looking at the appropriate utilization, both in terms of model of care as well as the skill mix composition within the organization. And the second being models of care delivery that very much advance continuity. And we know that continuity is so integral both for quality and for safety, looking at maximizing and expanding scopes of practice and also evidence-based practice. And there's a slide here to really emphasize the importance of shifting to health. And really our historic over-reliance on illness-focused health care has resulted in unprecedented needs in terms of comorbidities, emergence of chronic disease, and we really need to shift from a health care system to a health system that incorporates system planning, that looks at robust public health services, coordinated primary care, social and environmental determinants of health, as well as health equity. And effective nursing skill mix and organizational models of care delivery are also key to helping to enable and foster this change. So while we previously identified 4 key nursing pillars, we focused on nursing skill mix and models of care delivery for the report, the Closing the Gap report. So at a broad level, and the report goes into greater depth about this, we are seeing the complexity of care increasing across sectors, and I'm sure that if you ask any nurse today, she or he will tell you that the complexity of the care needs that they are seeing is unrivaled. And again, a lot of this stems from our over-reliance on illness-based care. At the same time, we've also seen a marked increase of the RPN share of the nursing workforce, rising from about 21.5% to 28.4% in a matter of 10 years. And at the same time, our Ontario has the second lowest RN to population ratio. So I'm going to hand things over to Anastasia. And Anastasia, talk to us a little bit about the evidence out there around nursing skill mix utilization, specifically the importance of RN utilization.
Sure thing. So in order to inform our report, RNAO conducted a literature review on models of nursing care as well as skill mix. We did have evidence from Ontario, but the scope of our search actually went internationally. And what we found was the evidence on nursing skill mix is clear. Replacing RNs with less qualified providers results in increased mortality, readmissions, adverse events, length of stay, and transfers of care. It's also associated with a decreased continuity of care, quality, safety, and satisfaction.
Great, thanks Anastasia. And you brought up an important point, and one I just want to clarify because we had a question from previous webinar. So we did look at Ontario-based literature. We also looked at Canadian-based literature, and where we made international connections was we're looking at similar healthcare systems to Ontario. That was important as part of our inclusion process. So while we're seeing changes in nursing skill mix that don't necessarily correspond with what we're seeing in terms of increasing complexity, we're also seeing changes in how nursing care is being delivered. And so the total patient care models, whereby one nurse, either be an RN or an RPN, depending upon the complexity and stability of the patient's needs, provides total care to a small group of patients, and unregulated providers would support the nurse with delegated tasks under their supervision. We're seeing a change now to team models where you have multiple providers. It could be an RN, an RPN, and one or more unregulated care providers are parceling out tasks and are caring for a pool of patients. And this is often driven by a thought that it would improve efficiency. But I think we know, and this is looking at the literature, that what is lost is that continuity, efficiency, safety. There's an increased risk of error, quality, as well as patient satisfaction. And at the end of the day, unfortunately, it's people who are often left not knowing who their nurse is for the day because there are so many individuals who are involved in parceling out aspects of care delivery. So I talked about total patient care, and the model of nursing care delivery that RNAO is advocating for is total patient care and primary nursing wherever possible. Primary nursing is where an individual patient is assigned to the most appropriate nurse, again, whether it be an RN or RPN, dependent upon the stability and complexity of the patient. And that nurse would act as the primary nurse throughout the entire care process, so trying to align that nurse as much as possible with the particular patient, depending upon scheduling and so on, to provide all aspects of nursing care. When that primary nurse is unavailable, again, there would be another nurse who would be providing total patient care to that individual. And we've seen this as the most effective means of ensuring continuity of care as well as care provider. And I'll turn things back over to Anastasia again to talk about the evidence around models of care.
Thank you. And so when we did the literature search on the evidence around models of care. We looked at outcomes on the patient and organizational level. And what we found was that functional or team-based models of nursing actually increased the instances of hospital-acquired infections, the time spent in administrative tasks instead of patient care. It also resulted in fragmentation of units as a whole, as well as hierarchical care teams, inequitable workloads, increased risk of liability, and adverse events. And what was lost with these models include psychosocial care, the clear accountability, continuity of care and care provider, as well as productivity.
Great, thanks Anastasia. So now that's a bit of context and background around the report and the processes that we used. Now we're going to get into the specific recommendations. The first recommendation is that the Ministry of Health and Long-Term Care develop a provincial, evidence-based, interprofessional health human resource plan to align population health needs with the full and expanded scopes of practice of all regulated health professions with system priorities. That is ensuring that there is the alignment between where we're going where the system is evolving or going towards and those policy priorities, aligning that with the nursing human resources that we need to get us to those objectives, and also, of course, population health needs, ensuring that we are going to have an optimal health system and health system of effectiveness that is meeting the patient's needs, and that we have the health human resources to get us there. That's absolutely paramount to have that plan. In the meantime, in the absence of that plan, we're calling on the Ministry and LHINs to issue a moratorium on nursing skill mix changes. Again, how can organizations effectively make decisions about changes when we don't have an interprofessional health human resource plan at the provincial level? So ensuring that there's that continuity and that connectiveness between organizational decision making and where we're going as a system and as a province. As well, we're calling for LHINs to mandate the use of organizational models of care delivery that advance continuity and that avoid fragmented care. Again, ensuring that the most appropriate nursing provider is utilized based upon the stability and complexity of the patient, and ensuring that that individual is able to provide total nursing care to that patient. As an aspect of the Interprofessional Health and Resource Plan, we want to see that the ministry legislate an all-RN nursing workforce in acute care within 2 years for tertiary, quaternary, and cancer care centers, and these are defined as Group A and D centers under regulation. And this refers to large academic health science centers who, by design, are meant to care for those with highly complex care requirements, and then within 5 years for large community hospitals that are defined as Group B hospitals under regulation. Those are large community hospitals, those that are greater than 100 beds, and often these centers are referral centers For smaller community hospitals, they are often deliver a higher degree of specialized care and have affiliations with academic institutions. And the rationale for this is that the ministry's aim is to have hospitals care for those who are of the sickest of the sick, those who have the highest care requirements, or those who are undergoing elective surgery, with the goal of, as soon as they become stable, that they would be transitioned into the community. And so therefore, when we look at the under regulation and legislation, the roles of different nursing categories, it's really RNs who are most effectively, who are able to provide nursing care to individuals with that level of complexity. And also, we're talking about RNs working with an increased number of nurse practitioners, as well as clinical nurse specialists who are working to their full scope. Our next recommendation pertains to home health care, and we're calling for the LHINs to require that the first home health care visit be completed by an RN, so that the RN can perform a holistic assessment of the individual's care needs, and then identify a plan of care that may involve care from total care from an RPN or an RN or unregulated care provider, again, dependent upon what the needs of that client are. We're calling on the ministry, LHINs, and employers to eliminate all barriers and to enable NPs, nurse practitioners, to practice to their full scope. Pardon me. We're calling for the Ministry of Health and Long-Term Care to legislate minimum staffing standards within long-term care homes and include at least one attending NP per 120 residents. Nursing workforce that includes a 20% RNs, 25% RPNs, and 55% personal support workers. And we're also calling for care coordinators that are currently within CCACs to be located within primary care to provide health system care coordination and navigation, which really are core functions of interprofessional primary care. If you're interested in learning more about this recommendation, including a proposed role description for a primary care-based RN coordinator, I would refer you to RNAO's submission in response to the Minister's Patients First discussion paper, and that is available on our website. So to learn more, by all means, visit rnao.ca/mindthesafetygap. That is the URL that I mentioned at the beginning of the presentation, and that's the one-stop shop there. My contact information is on there, as well as that of our CEOs, and we would welcome to hear from you and to get your feedback. As well, if you are involved in social media at all, we do have some active hashtags on Twitter, including #MindTheSafetyGap, as well as #StopRNReplacement. And we would welcome your tweets and as well as discussion on social media. In addition, I also mentioned that there is a second phase of RNAO's Action Alert in response to Mind the Safety Gap. And that has been circulated, I believe, twice to members, and I would encourage, you don't have to be an RNAO member to sign on to that, so feel free to share with friends, family, colleagues, coworkers, and encourage them to sign on to that. So that is really a summary of the report, and so the two dual objectives of the session today were first to provide everyone a summary as well as links to get more information if you should be in, as well now as an opportunity to ask questions and offer, and hopefully we can offer any clarifications that may be needed. So Anastasia, why don't we begin the process of going through the questions? And I do invite anyone who's interested to please use the chat box, just because we do have, looks like over 75 people on the line, and so this is just the easiest way of managing questions. Okay, so our first question is, what is the cause of this increasing complexity of care? Is it the aging population, poor policies around medical coverage for refugees? That's a great question, and I think that kind of ironic because it's a complex answer to regarding complexity of care. I think that there are many factors that are driving this. One is, of course, changing demographics and having an aging population, but this is not to say that this is at fault of this group, because it's not. I think one of the key things that has been driving a lot of the complexity is a historic over-reliance on illness-based care, having a system where you go to hospitals to kind of patch you up and then you get sent on your way, not paying enough attention to the social and the environmental determinants of health, looking at a lack of accessible primary care services, and then taking a step further and looking at inaccessible primary health care services that include robust health promotion, as well as having an accessible and effective community care sector. And this is not in any way, shape, or form meant to diminish the amazing work that's going on within the community, but I think many of us would agree that we certainly need to look at expanding resources within the community and improving the community's capacity to respond to care. I think a lot of these factors are coming together and creating unprecedented levels of comorbidity, chronic disease, illness, and so on. That's driving a lot of the complexity around that. Anastasia, is there anything you wanted to add?
No, I think you've covered it.
Okay, great.
So our next question is, these team models, weren't they what nurses did years ago?
Yeah. Another good question, and thank you. So we've seen ebbs and flows, I think, are cyclical changes within organizational models of nursing care delivery, whereby these models seem to emerge, often with attempts to drive efficiencies, and then they're abandoned because they don't produce the outcomes that they originally thought to have produced. So we are seeing, yes, the resurgence of something that was previously abandoned because of it wasn't producing optimal outcomes, I think, for people or for healthcare institutions.
And just to add to Tim's answer, in the report we actually provide a historical overview of the 4 major models of care delivery, and in it we present that these team or functional-based models actually emerged during wartime, so the applicability of them to our current health system is questionable.
Yep, absolutely, Anastasia.
And so our next question is, any recommendations being considered related to health equity and public health?
Yep. So throughout the report, public health and health equity are paramount. We do talk about public health throughout our analysis. With health equity, we also do recognize the importance of the social and environmental determinants of health. However, it was really beyond the scope of this report to capture those specifically within the recommendations. Because the report focuses on nursing skill mix and organizational models of nursing care delivery, public health is, I think, in a unique position within the health system in that there is a legislated requirement that public health units have, or the public health nurses are RNs, and that is enshrined in the Health Promotion and Protection Act. I think that is something that is unrivaled elsewhere within the health system, that there is that clarity. Now, that being said, we're also very mindful and watching very closely changes that are underway within public health to ensure that the role and the presence of public health nurses is in no way, shape, or form diminished, but in fact actually expanded. Because when I brought up earlier in the presentation RNAO's model for health system effectiveness, looking at health equity and the determinants of health is absolutely paramount in achieving health system effectiveness, and public health nurses are central to driving that, given the robust knowledge that they have around the determinants of health. And when we also looked at the policy agenda and the drivers within health care policy reform, talking about like increased public transparency and the involvement of community within health system, health service delivery, it's public health nurses who I think have that knowledge and ability to mobilize communities and to engage communities. And so certainly that's a very critically important role. And that is included within the actual report itself.
Okay. So our next question is there any evidence on how the LHINs have managed HHR within their mandate?
So we don't get into that specifically within the report, but I can speak to it just from experience. And there is wide variation amongst the LHINs in terms of their health human resources planning, some who are much further along than others. And certainly we are looking to have a provincial plan in place so that way we can have consistency as much as possible, consistency that can be adapted for the local context, which is where the LHINs come in. But it's important that the ministry also preserve its stewardship function, and a key enabler of that will be a provincial interprofessional health human resources plan.
So our next question is, any impact on human resource allocation for nursing students, BSCN prepared? Despite the new graduate guarantee program in Ontario, not many organizations are actually utilizing the program due to budget constraints. Is it because more RPNs are being hired?
So certainly there's a lot of impact on the report for nursing students, because we're talking about, you know, both the present and future of the health system and where do we want to move towards. And so some of the recommendations are call for immediate implementation, and certainly which would impact new graduates and those who will be entering into the system, and others are we're calling for taking an effect in 2 to 5 years. This will impact future graduates as well. We know that the Nursing Graduate Guarantee Program is very much a integral part of advancing nursing health human resources planning, and certainly has been embraced by many, many thousands who have participated, as well as employers. It's beyond the scope of this particular report. We didn't look into specifically the Nursing Graduate Guarantee within the context of Mind Safety Gap, but it's an important, I think, discussion to have, and I'd be happy to connect with the individual who's posed this question to talk about his or her experience. And I shared my contact information at the end. Anastasia, is that slide still up?
Yeah.
Perfect. So I would invite that individual to send me an email and be happy to chat more about his or her experience.
Okay, so our next question is, how are the numbers of students graduating from the various nursing programs determined? Is there any planning at the ministry level for this aspect of the HR management of nursing?
So it's my understanding that the number of students graduating is based upon the number of positions that, or number of nursing seats that are funded by the Ministry of Training colleges and universities. And then is there any planning at the ministry level for this aspect of HR management? So certainly this would be an integral part of an interprofessional health human resource plan, ensuring that we have an adequate number of students to align to what the workforce requirements are. In terms of what's going on right now around this, I really can't speak to that, but that would certainly be a very important element of the interprofessional health and resources plan.
Our next question is, in terms of population health disparities and addressing the issues refugees are bringing to hospitals, Do we see a future partnership with social services and public works?
So I think that's looking at more of, I think, and if the person who's posed this question disagrees, let us know, but I think it's talking about looking at alignment between health and social services as being an important connection to make, and certainly something that we'd want to see, again, linking the social and environmental determinants of health to health and health care as being critically important.
Our next question is, can HHR also be addressed by requiring magnet designation of all hospitals in Ontario?
So we didn't specifically look at magnet designation for this report, and it's something that certainly we are familiar with, but we would need to look at that a little bit more closely.
Yeah. I believe there are more requirements for magnet designation than simply an all-RN workforce as well.
Mm-hmm.
So our next question is, an all-RN nursing workforce recommendation appears to disregard the continuum of care services provided in hospitals. Is the recommendation meant to suggest that ALC patients, outpatients, and day surgery patients can only be adequately cared for by an RN workforce?
So the policy priority that's being put forward is that hospitals will increasingly more and more be caring or designated as centers that are caring for those with most complex care needs. And so to be able to accommodate that shift, we're calling for an all-RN nursing workforce. And certainly we are seeing those changes already underway where hospitals are seeing decreases in their ALC patients. They are prioritizing service for those who are of the greatest complexity of care. And that's by all indication where, the government, certainly what they're saying within their policy proposals wants to go, with hospital care being, of course, the most costly, and also there's certainly from a patient satisfaction perspective, people want to receive care as much as possible in the community. So hospitalization would be seen really as that last resort. And so if an individual has needs that are stable or predictable, not that level of complexity, then we question why they would even be in the hospital then in the first place. And so that recommendation, and we're not calling for it to happen overnight. We're calling for it to happen as a stage process. So the tertiary, quaternary cancer centers, who are by design meant to care for those who are the most sickest and complex, we're calling for that to happen within 2 years, which I think is a pretty generous timeline. And then also within 5 years for those large community hospitals. I think that's an important point to reinforce.
And if you would like more information on which hospitals or which types of hospitals are included, we also have an appendix in our report which is based on Regulation 964 of the Public Hospitals Act, which is where these classifications came from.
Great. Great point, Anastasia. Thank you.
So our next question is, have we looked at policies around work life for Ontarians? People commute to work a lot and have limited time to be active. We're built out, not up. How do we build in time for people to engage in healthy lifestyles and promote community engagement?
Oh, it's a very good point. It's not something that we specifically looked at within this report, but certainly looking at, I think this is our work-life balance and the health of nurses and also the health of communities. We specifically didn't address work-life balance within the report, but it's an important component for sure.
So our next question is, did your research differentiate between the educational preparation of the RNs and RPNs? Many of my RNs are diploma prepared, which is essentially the RPN program of today.
So in terms of the research, we specifically looked at care delivered by RNs. And Anastasia, you may need to go into a little bit more depth in terms of what that particularly means. But we were very clear that we were looking specifically for RN-delivered care, and also looking at jurisdictions that, well, either Ontario-based research or Canadian research or international research where there are comparisons to Ontario.
So just to add to Tim's answer, we didn't, I guess, disregard evidence based on educational preparation. We really looked at the categorizations of RNs and then diploma-prepared nurses, whether they were RPNs or LPNs. We did focus our lit review on research that has emerged in the past 10 years, and so within those 10 years there has been a move to have RNs be BSCN prepared, but we didn't focus so much on the educational preparation.
And also I think that I would caution in asserting that the RPN program of today is the RN diploma program. I don't know that that is a fair comparison to be made. Certainly we do have RNs who are diploma prepared within the province, and through many years of experience are practicing effectively within their scope of practice. So I would just caution that to be mindful. I'm not sure that that is absolutely to say that the RN diploma program is the exact same as the RPN diploma program of today.
So our next question is, I've heard that as CCAC nurse case managers retire, they are being replaced by non-nurse providers. Is this not contributing to the safety gap? What recommendations to curtail this disturbing trend?
So that's, thank you for that. I would also invite this individual to specifically get in contact with me as well, because we do know that RN-led care coordination is effective, and there's quite a wealth of research on that. And that's summarized within our Enhancing Community Care for Ontarians ECHO paper. And so certainly we want to see RNs effectively utilized within the care coordination role. And if there are attempts to diminish that in any way, I'd be very interested to hear about that.
So our next question is, for your recommendation on the HHR split in long-term care, is this based on a particular model, evidence, or best practice? What is known about the current split in long-term care homes?
So what we did is we did look at evidence. We've also looked at what other organizations have been calling for. We've had discussions with colleagues within long-term care, and certainly we understand that there are the complexity of resident care requirements has increased significantly, and long-term care homes are seeing patients that are coming out of hospital much sooner, and certainly this is increasing the demand within long-term care homes. And so we also look at what is currently in place within long-term care, what is that complexity of care looking like, and then proposed a model that does recognize the important role of unregulated care providers within that setting, but also that will increase the proportion of regulated staff, and to ensure the active presence of regulated staff in care delivery within long-term care homes. And so we really did have a multifaceted approach in terms of developing that breakdown, and I do think that it is relatively consistent with what other organizations have called for as well. So
that brings us to the end of the current set of questions that we have. We do have a few minutes left if anyone else would like to add another question to the chat box.
Okay, well, seeing no other questions coming in, I think we might wrap up things a little early. And I want to thank you all very much for participating in the webinar. If you do have any follow-up questions, by all means, you can get in contact with myself, and we'd be happy to chat with you. We will be planning likely more webinars within the future. And I would encourage you, if you are interested in wanting to participate, by all means. We will likely do the same presentation at the beginning part, but then would again be open up to questions and dialogue. And so, oh, do we have one more?
We have one more question. It's how do you know that the acute care organizations are not evaluating the effects or outcomes of their changes in care delivery models? Have you explored the human health resource strategic directions or plans of the acute care organization?
Yeah, well, we do know that, we do outright know that some hospitals are not evaluating the organizational models of care delivery. Others are. We've seen some concerning results, especially from the past, when these fragmented team-based models were first introduced, and it's that evaluation data that is actually concerning us. In terms of some of the ongoing evaluations, I think there's been some concerns around how things are being measured and what is being measured. And again, looking at history and what previous evaluation has said, it was really quite concerning. And then in terms of exploring strategic directions / plans, so that really is, I think, the basis for a lot of the recommendations, is looking at what are the strategic directions of the health system, right? So, of course, we all belong to one health system that's overseen with the ministry as a steward and LINS as regional health planners, funders, and evaluators. And so the strategic priorities and directions of the system really are to focus care in the community and to reserve hospitalization care for those who are the most complex. That really has been driving so much of this work. Okay, well, so again, thank you all very much for the opportunity to connect with you this afternoon. And we look forward to delivering future webinars and also hopefully engaging with you in the meantime if we do have any other follow-up questions. So with that being said, I think we're going to call the webinar to a close and wish you all a very happy afternoon. Take care.